Hello and good evening, everyone. Welcome back again for those of you that have been watching our 4-part series. We took a week hiatus and we're back again. Today we're going to be talking about biomaterials, and we're going to be talking about grafting. I'm very grateful, first of all, to Geislich for providing a lot of the material in today's lecture and next week's webinar. We're splitting the bone grafting because it's a larger subject into 2 parts. Today we'll be really talking about what materials are available, and next week we will be talking about the application of those materials, although today we will be talking about where these materials are indicated and what is out there. I largely use a number of things. I will talk through, although it's been kindly provided by Geislich as a presenter pack. I will be talking today about, in between the slides, just saying what I tend to do, because I don't always follow exactly all the ways that they've suggested, and some things that I've learned over a period of time to do. I found better success in my hands, but that's not to say that's the only way of doing things. Without further ado, let's get started. So bone grafting in dentistry, okay. All materials that we're going to be talking about have either an osteoconductive, an osteoinductive, or osteogenic properties. And initially, I just want to go through some basics. Apologies to those of you that are seasoned in this particular subject. We try and make these seminars so they encompass everybody from and everything from beginners all the way through. And I'm happy to answer questions. If you again would like to see any of these techniques, or you'd like to see them firsthand or come and assist in them, our offer is always open to come to the surgery. Contact us, come and see us. It's not an offer that many clinicians put out there, but we're happy to recommend you. Also, as I said, we're trying to create a community that's collaborative, that we help each other, in times where everybody's competing against each other, and see, share tips and share experiences. So please do follow us on Facebook, and like us, and please follow us on Instagram too. It greatly helps, and the bigger community we have, the richer these webinars and our learning will be. So, we will be talking about autografts, allografts, demineralized bone matrix, DBM, synthetics, bone morphogenic proteins, and I'm just putting out sort of stem cells, but that's a huge subject. We won't be covering that in great length here because there's not a lot of application, as you know, for it. But I will be talking about other parts to do with these things. I predominantly use DBM. I don't only use Geislich. It's a great material, BioOS and BioGuide. I do like the Straumann Cerebone as well. BioGuide is a great membrane. I use it in certain situations, a lot of situations actually. And one of my favorite membranes, other than BioGuide out there, is the Jason membrane by Straumann too. The particular thing I like about that particular membrane is that it's drapable. And I find that the control of it is easier in my hands. But please let me know if any of you have other experiences or other membranes that you use, and maybe suggestions to me of things that I've not come across. Okay, so bone graft has aspects of more of one of these properties, as I said. Osteoconductive material basically acts as a structural framework for bone growth. Demineralized bone matrices, the various 3-dimensional makeups of the material detect conductive properties, basically. The osteoconductive, this material actually contains factors that stimulate bone growth and the induction of stem cells down a bone-forming sort of lineage. Bone morphogenic protein is commonly found in transforming growth factor. It's a beta superfamily, TGFB. It's not as easy to get hold of and use. You need TGA for it. There are bones out there that bone substitutes and grafts out there that do contain BMP. One of the ones that comes to mind, which I have also used, is Mineros by BioHorizons. So osteogenic, the material directly provides cells that will produce bone, including primitive mesenchymal stem cells, osteoblasts, and osteocytes. If you're unfamiliar about what those do, please just go back and have a look. Going back to school a bit dental school. Mesenchymal cells can potentially differentiate down any cell line, and the osteoprogenitor cells differentiate to osteoblasts and then osteocytes. Cancellous bone has a great ability than cortical bone to form new bone due to its large surface area, and that's quite important. Autologous bone grafts, such as fresh autograft and bone marrow aspirate, I'm not sure many people use those, but that's promptly in there because it's indicated in things mainly outside dentistry, actually, is the only bone graft material that contains live mesenchymal precursor cells. Autografts. These are bone graft transferred from one body site to another in the same patient. I tend to use a lot of this. We will go through indications, as I said, next week, and I'll show you how I tend to harvest autograft. I've gone away from the early days when I started a few decades ago with implantology and bone grafting, from taking block grafts. For me personally, I'm not saying that's, you know, a lot of my colleagues still use it with great success. I'm not saying I don't use it at all. I do. It's just become less frequent. My main concern is the post-operative complications and pain in particular for the patient. And you have to remember that there is a risk of morbidity of the donor site. You obviously have to graft that too. So you're almost sort of double grafting, taking bone from one end to put to the other, and then you have to basically cover your tracks that way. They're osteogenic, osteoconductive, and osteoinductive. Least immunogenic. There's cortical cancellous or corticocancellous, and you have vascular and non-vascular. One of the sites that used to be a main go-to for me was the anterior mandible. I do less and less of that. Again, as I said, I don't take blocks as much anymore, largely because you do, no matter how careful you are, sometimes have problems with water sensation or lack of sensation when the incisal nerve and that area, and it is a delicate area to work in. You have to be very precise. In most of those cases, if I am taking a block, I prefer to go to the retromolar area. Allografts. These are bone graft obtained from a cadaver or inserted after processing. Most commonly used bone substitute. The properties are osteoconductive, only due to lack of viable cells, basically. The degree of osteoconduction available depends on the processing method, fresh, frozen, or freeze-dried, and a type of graft, whether it's cortical or cancellous. And again, you have cortical cancellous and corticocancellous in this category. Demineralized bone, or DBM, matrix. It's an acid extraction of bone matrix from allografts. It removes the minerals and leaves a collagenous and non-collagenous structures and proteins. They use also a process of sintering, and you know, some of the better qualities of these tend to be where they've perfected the sintering, and it usually is done over a longer period of time. It creates an environment and porosities for more porosities for, you know, bony ingrowth and vascularization. Their properties are that they're osteoconductive with structural support and osteoinductive despite preservation of osteoconductive molecules. Synthetics. I don't use synthetics a lot. In my hands, I found that they're not as successful as some of the other grafts. But although I have seen colleagues of mine use synthetics very successfully and actually rely on them, and that's their go-to, and they swear by them. Alternative to autografts and allografts, obviously, it's usually made in a powder, pellet, or a putty form. I've probably had the least success with the putty form. I have had dentists that use putty exclusively, particularly for socket preservation, and they get great success from it. And they seem to find it's very easy to do and easy for the patient. The only thing about synthetics that they're osteoconductive only. Bone morphogenic proteins, BMPs, they're osteoinductive only, stimulates undifferentiated perivascular mesenchymal cells to differentiate into osteoblasts through CRNM3 kinase receptors. And then you get platelet-rich plasma and solely also osteoinductive. If we're doing cases, in certain cases, I have taken with a vacuum blood from a patient to create PRPs through using a centrifuge, but quite often I don't do that anymore. I usually get most of the patients having procedures, they tend to be larger. That's where I use PRPs, and I prefer to do those procedures largely for the patient under twilight or IV sedation. And I will usually get my anesthetist to do that for me, and then we will separate out the PRPs. Okay, so Geistlich offer a huge number of biomaterials. We'll be going through a bunch of them today. We're going to go through mainly the bone. I will touch on BioGuide if we have time. If not, we will pick that up next time just at the beginning. But I just want to give you a view of what is out there and its indications. The application and the practicality and procedures we will go through next time. But this is important for you to pick that up because you need to know what to use before you use it. Okay. So products. They mainly fall into three categories, which is Geistlich bone substitutes, which comes in like BioOs, which is a loose form, granules, which we'll go into in a moment. You get Geistlich BioOs collagen, which comes in basically a cube. You can cut that to size, so easy to use. And then you also have the BioOs pen. The membranes come in the BioGuide compressed, the perio, and the shape, which is basically used. The perio, I won't expand on because I don't use it and I haven't used it because I'm not a periodontist and I don't really take on periodontal cases myself, but I will talk about the others. And then you've got the Geistlich matrices, which are basically mucografts. Although there is, within that category, you also have a fibro guide. Okay, so BioOs. I will go through a little social slides showing these symbols, and these are fairly useful in the fact that A, it's easy to identify on the packet, but more importantly, when you're looking at procedures, and if you go to the Geistlich website, or you'll see that they use these symbols, so it's an easy way for you to actually pick up what's being used and its indication. So, Geistlich BioOs is an anorganic bovine bone mineral. It's made from the mineral part in Australia and New Zealand of cattle bone. We used to, way back in the day, only be able to get it from certain resources and banks, but I'm glad to say that it's now local. It's highly purified osteoconductive mineral structure. It's produced from natural bone, and it has a multi-stage purification process. So it is to really strict safety regulation. That's important. It's important because you're using the material, you're responsible for using the material. And remember, when you're using any of these, you need to get consent for the patient. Not only do you need to get consent for the patient, you need to warn the patient of the relative risks of using materials, complications as well, and also the source of the material, because for various reasons, particularly religious, you'll need to decide whether you're using a bone from another human being, or you're basically using bone from a cow or a pig, okay, whether it's porcine or bovine. It's a natural origin, and as well as structure comparable to mineralized human bone. Look, this is a statement that Geistlich made, and there is decent evidence to support this. My preference is to use the patient's bone to some extent, but I'll go into that. I don't use that by itself. I usually tend to use a mix, but we'll go through the indications of that. It's recommended for filling bone defects and bone augmentation, so that's fairly obvious. The augmentation and reconstruction of alveolar ridges, filling of sockets, implantology, and again, periodontology, predominantly GTI and guided tissue regeneration. So, in terms of bone grafting, as discussed, it's mainly used a lot for the alveolar ridge. Now, one of the things that you have to remember with the ridge, it's much easier to get width, so fill a hole and get a defect that may be superficial one-sided rather than two-sided or through and through. It's much harder to get height. The actual, consistent way of getting height, or clinically proven, and we know that, we can't have blind controlled trials for everything, although that is the standard we want to get to give evidence. The consistent way, or scientifically proven way, is distraction osteogenesis, where a section of the jaw is separated from the bone by a small margin and fixed into place by a mechanism, and that mechanism is extruded at a certain rate, so bone cells grow into the gap every time you extrude it, and then the bone ridge is lifted, as it were, or look to be lifted. They also used for root resection, apicectomy, and cystectomy. Extraction sockets to enhance preservation of the alveolar ridge, elevation of the maxillary sinus floor. This is particularly important because evidence shows that this type of material is far more successful, particularly with sinus lifts, rather than using autogenous bone. Filling of periodontal defects and filling of peri-implant defects. You'll find as I go through the slides that, and this presentation, that a lot of these applications are listed for all their materials, whether or not that may be the case. That's basically what they're saying that they use for. I tend to use different things for different situations. So as me, I don't really cover sort of probably a third of the things here because I don't use them for those. And I don't deal with periodontal defects. Mine is mainly extraction sockets and alveolar ridges, and also elevation of maxillary sinus floor. Bias comes in several granule sizes. This is useful. It comes in two different sizes, small and large. I tend to use large for sinus lifts and tend to use small for local sites. My technique with this tends to be that I like to try and get a 50-50 mix of the patient's autogenous and granules. The advantage of the 0.25 and the 0.5, if you do a lot of bone grafting, is the fact that you may have a small defect and you don't want to buy a gram of bone because it's not cheap, and you don't want to end up literally getting rid of most of it because you've literally used a quarter of it. So that becomes quite useful. They come in pack shots. It's basically granules, 0.25 to 1 millimeter. And there's a shot with dispersed granules that come in different sizes. It basically is forming a matrix. It comes in the form of a sealed sterile pot. There's the icon, as you can see, and comes in a blister pack. So it's easy to have sterile transfer and drop onto a sterile environment where your scrubbed up nurse can pick it up, open it, and actually get it together. With these, I like to mix it, which you will see the handling of it in a moment. I like to mix this with some saline, which is the indicated use. Everybody should do that. Sometimes we'll use some of the patient's blood to mix in there too. And realistically, you want to remove enough moisture so it has a sort of a wet sand feel to it. It shouldn't be too dry because then it sticks to everything and it's hard to handle. Having a bit of moisture and just a little bit of moisture on the surface. That's the large one, which pretty much comes in the same format, and you can see the larger granules. And the same, it comes in a pot, there's a symbol, and there is the blister pack. Okay, just some on the handling. The small granule. So within the packet, you have the blister pack. The blister pack, you can see on that corner, has a point at which that peels back easily. It can then be sort of dropped out. I hope this is the sterile part of it, but I'm sure it's just a demo because they don't look like surgical gloves to me. Put into your dish the addition of saline or blood. As I said, I like to wet it with the saline so I can see how wet it is, and then add blood. And mix it through thoroughly, because what happens is, without putting too much pressure, is that you don't want dry bits underneath. This is application into the site. Here there's a buccal defect, so they're expanding the buccal side of the implant. The implant there has been left sort of slightly higher for whatever reason. Emergence profile, gingival aesthetic line. And they're adding the bio guide. In these cases, in that case in particular, I don't actually, I don't like putting just bios directly or cerebone directly into the site. I like to have a bit of a mix if I can harvest some bone. I predominantly tend to use a bone scraper in the local vicinity of the graft. Usually if we're going for that area, for example, it'd be superior maxilla. You will need to expose that and have a clean view of it, and you need to be careful with what you're doing so you're not sort of digging a hole in one place and hitting any vital structures, or particularly roots of adjacent teeth. You'll find that there's a very thin layer of bone over the teeth. They're not placed in the middle of the ridge like you find or you're trying to achieve with implants. This is the pen. The pen's user friendly. So it's quite easy to use. It does come with a curved end as well that you can get, and that's very easy to use in posterior areas, particularly the posterior maxilla. So it allows you to have precise placement. And it then reduces all that procedure time. I don't see that as a major deal because I'm a firm believer in overbooking time. I don't like clock watching. I suggest you do the same. Make your life easy and make your dentistry enjoyable. It's easily moistened. There's no waste of granules because of the smart design. I think virtually every single one of these bone substitutes has that. And it's ergonomic design with curved applicator tip and has optical access to posterior areas, as I discussed. And again, this one largely for augmentation of alveolar ridges. I'd say more in the form of within a socket, even if it has defects either side. It's particularly good for filling extraction sockets. You need to make sure that once you've got that there and put the guide in, that you're able to have full closure, tension-free suturing. If it's a small site, I will just use a simple interrupted sutures. If we are lacking tissue, then I'll use horizontal mattress sutures and interrupted sutures to toughen up the tissue so we have more tissue afterwards, and they're trying to achieve a decent amount of keratinized tissue. It's preparation of implant sites, dehiscences and sinus. The sinus floor augmentations, this is quite useful in the larger size, because rather than sort of ladling it in, you can then, if you precisely squeeze it in. A lot of people tend to do the sinus lifts with the graft and then a membrane only on top. I like to put a membrane on the back. I particularly like this. I exclusively use a piezo because I think the rate of perforation or micro perforation is plus 40% by just doing it manually, and you can drop that down to less than half by using a piezo. I'm not up to date at the moment with the latest statistics on that, but it is always better. But even if I have a microperforation or anything else, I don't want granules or anything else traveling into or beyond the membrane into sinus. So I like to put a membrane behind the graft and then fill it, and then double membrane on top. I also tend to use a technique where if I cut a window, I elevate the tissue with the bone still intact on it. I'll then remove that at the end and use that over the access with my double membrane and periodontology again. Again, as I said, it has pretty much the same indications as a lot of the previous materials that we've discussed. So again, it's for defects, alveolar ridge, extraction sockets, sinus floor. and periodontal defects and peri-implant defects as well. Somebody did ask me about peri-implant defects and peri-implantitis, and asked me, if they were to attempt to perform alveoplasty and get bone back up the implant, what would they do? I have discussed before that, and that's not been very successful in my hands, and I'd love to know from any of you that use a technique that works for you. I'd be very interested, actually. But in the past, they've used basically a barrier over the bone to separate out that area. The exposed implant surface is thoroughly cleaned. They use a mixture of citric acid in a powder form to decontaminate the area and prep the area, and then use a bone graft to put onto the area, but with a prep of doxycycline in powder form or paste form put on there too. I found where I have attempted this many years ago, that I end up having a worse situation than a better one. But as I said, that's in my hands. However, there's some very interesting study at the moment, a lecture that's going to be released pretty soon. It may even be out there soon. I urge you to go and have a look for it. Once I do find it, I'll post it on our Facebook. And it's the use of PrEP and Emdogain, not only in alveoplasty and getting height around affected implants, but also in bone grafting in general. And success rates are quite amazing. I would like to have a look at this in further detail, because I don't want any of my patients to be guinea pigs, but the people behind the studies are some big names. They have some decent trials out there, and they have some decent clinical trials out there. It's not just peer review. Okay, so Bios pen again comes in the same granule sizes. There are the pens. So they have the pack shots, and there's a 0.25 and the 0.5, although that looks more like the 0.5 and the 1 gram, or 0.25, 1 gram. Again, in the blister pack, so it's easy to use. And there is a larger granule size as well, again in the blister pack. There's the curved tip that I was talking about. Makes it quite easy to get to those posterior areas, and just makes it a lot easier for you. Okay.
Geistlich BioOs is the most used bone substitute in oral bone regeneration worldwide. It's used approximately 2,500 times per day, and more than 4 million patients have been treated. Geistlich BioOs has been in clinical use for more than 25 years, and it is scientifically documented in several hundred studies. New Geistlich BioOs pen. Nothing changed, just improved. The Geistlich BioOs pen combines the #1 bone substitute material with comfortable use and optimal access to the defect. The material can be easily moistened and offers very good consistency. Furthermore, its simple use saves time and guarantees clean handling. Tear off the protective seal and unscrew the protection cap. This exposes the applicator and filter cap. Do not remove the filter cap from the applicator at this step. Draw up either sterile physiological solution or patient blood.
Patient blood is better here.
Alternatively, use a separate syringe to moisten the Geistlich BioOs. Remove excess fluid by gently pressing the plunger. Replace the filter cap with the curved applicator tip. And the Geistlich BioOs pen is ready to use. The Geistlich Bioas pen is available in 3 variants. The 0.5 cc variant with small granules for small defects, and for larger defects as well as sinus floor elevations, the 1.0 cc variant with small granules or the 1.5 cc variant with large granules. Depending on the size of the defect, more than one Geistlich Bioas pen might be necessary. Geistlich Bioas pen, unwrap, moisten, use. Geistlich Biomaterials, natural bone regeneration for a better quality of life.
Okay, I prefer to use blood with a pen, if I'm using a pen, mainly because I can see the wetting, because it's a different color. And also you've got a number of things in there, you know, PRPs, etc., that will help the situation. Okay, the block. The block is used, I don't use the block as much, mainly because if I had a block, I'd probably crush it down and use it with some autogenous bone anyway, but it's a very useful thing to have because you can cut the block down and fit for size, and it's just easy to use. Again, it's recommended for augmentation of alveolar ridges, filling of sockets, again, preparation of implant sites, bone diuresis as the sinus floor augmentations, although with sinus floor augmentations, probably not the way that I would go. For me personally, I prefer to use a granular, mainly because I can pack that. Say if it's in a bio pen, and earlier said, you may need to use more than one. Unless it's a very small sinus lift, in most cases where I'm lifting the sinus, I'm probably placing 2 to 3 implants later in that area. I would definitely be using the 1.5s, at least 2 pens. You don't want to overfill the site, but you don't want to underfill it and then find that 6 months later the patient comes back and there's been some marginal resorption and you still have insufficient bone, and then trying to lift again in a site the way you've placed bone can be fairly difficult. It's not impossible. It requires a different skill set, and you need a window that's now higher than the original one that you had to basically access the sinus, but it just makes things more difficult. Okay, so as I said, look, a lot of the indications are the same for reconstructive periodontal defects, root sorption, apicectomy, cystectomies. Filling of extraction sockets is, I think, the main one here, and that's probably what I would use it for most, because it's nice and convenient to put in. You would still pack it gently so that it fills the socket and you get good adaptation of it. I don't use it for elevation of maxillary sinus floor, and as I said, I don't really do much with periodontal defects, and I stay away from peri-implant defects. Okay. Okay, it's a spongish block, essentially the same material as BIOS. There is a study there, Felice et al. If you of those who want to go up and read it, it's a very interesting study for clinical oral implants. And due to its brittle properties, it's recommended for interposition grafting of the alveolar ridge. Again, I've already discussed what I tend to do. It comes in a block that's 1 centimeter by 1 centimeter by 2 centimeters, and you can just basically break that up for use. Again, it's in a pack, like many of the others. There is a symbol, a blister pack that can be dropped out with a block, and that's that. So next is a BIOS collagen. So similar, it comes into a block. It's 90% Geistlich BIOS granules and mixed with 10% porcine collagen. It's a bit like the other block as well. It's easy to use, it's hydrophilic, easy form, easy to trim, easy to handle, and it has I found the collagen one, the BIOS collagen, has better adherence. It's true, it does have good adherence. They're not saying that the other one doesn't, but this one just has better adherence. Again, augmentation of alveolar ridges, filling with extraction sockets. Same with the implantology. Now, I say again, this would probably, in my hands, I predominantly would use this for filling of extraction sockets. I have seen it for buccal defects being used very productively to create a decent bulk, and especially where you've got aesthetics and the smile line and gingival aesthetic line to bulk that out. I've always find though after grafting that with these particular cases, which I regard as being advanced or complex cases in the SAC classification, that you always need soft tissue surgery afterwards and soft tissue enhancement, not only for keratinized tissue, predominantly if it's keratinized tissue, I use an apically repositioned graft, but connective tissue grafting, really, just to get the contour and the bulk of that right. Pretty much the same indications, but as I said, sockets would be the main one for me. Buccal defects, maybe not myself, but I have seen it being used very well for that. It comes in 100, 250, 500 milligram packs, and they have combi packs too. Okay, there. Blister packs again, much the same. They tend to keep that consistent. Here's its use. Pretty much every product known, regardless of the company, comes in a blister pack. Now, as you saw in the socket there, I hope they were going to actually close those sockets. That's important. One of the other things I should mention, before if we have time this time to go to membranes or next time, we're coming close to the last part of this bone grafting one, is that I find personally that if I use autogenous bone with the graft material, I get more graft or a better graft when we finish. I get better volume, better height, better width. But that's not the only thing. There's a number of factors that you need to make sure you have a successful graft. One of the other key factors is obviously using a membrane so that you're not getting soft tissue infiltration into the site. And also, if you're using one-way membranes, you're protecting the site. But more importantly, stability of your membrane. So, if you can tack wherever you can, but if you can't tack, then learn to use a suture within the flap that ties the membrane down, which will be very different to the suture used to close the access and the flap. If in doubt, as I said, come in, have a look. If we have, I do grafts all the time, almost every day. So if there is one of interest where we're going to be using this, or you want to learn a particular technique, contact us. Just use the email, use the Facebook group, even use the Instagram, and come and have a look. Okay, this is a product by Rios, and Geistig have exclusive rights to this. And what it is basically a titanium mesh used for large grafts, specifically and I was getting onto this before membranes because it's sort of like acting in meshes forming into that category that creates structure. It's basically made specifically for that patient and for your graft, which is great. It's not the cheapest thing, but you know, it's at a cost factor because of what it is. It's very efficient and very good to use. I love using this particular mesh. In this picture, you can actually see the mesh. We're going to go into it in a minute. And it's actually got guides for the implant holes in advance. Now, you don't always get the ideal situation where you take the mesh off and it's perfect afterwards, and you've had bone fill all the way in. The technique I'll go over in a moment. So quite often, you know, those guides are not useful because once we remove the membrane, it's got a little area at the back, sort of a line that you can see, a hollow line, and that's the back of it. And you can then, when you remove it, you break that and separate it out. And those guide holes are designed so you can place the implants or give you an indication as to where they should be placed as a guide. But usually what happens is that I would normally take a scan and reassess and either place freehand depending on what I want to do and the situation, or have a guide to help me. I don't tend to rely as much on surgical guides. They're guides after all, they're not absolutes. So I would maybe use a surgical guide to give me some indication, usually pilot level, rather than fully guided. Certain cases I do use fully guided, but I'd be more interested at my point in my career in implant industry to be more of a prosthetic guide. In our practice, we move more towards doing the thing that Straumann have, a smile in a box, where a patient is coming in, we know what implant it's going to be, we've got a guide for that implant and that patient put in there, be it fully guided or just pilot hole. I like pilot hole because I can assess, take x-rays and see that I'm happy with where the actual guide is sending me, rather than just blindly drilling through. And that's why I'm not such a big believer in sort of flapless, because things can go wrong. And ask me how I know, because they have gone wrong. I'll see if I can dig up a case that I'll show you where it's not gone according to plan. So I just prefer to do things in that manner. It's a customized 3D printed titanium scaffold developed to regenerate complex alveolar bone defects that can be combined with our best-in-class biomaterials. That's a Geistlich statement on it. I find I've used this a fair bit, and I quite like it. It's used for a lot of different situations and different defects. And as I said, it's in partnership with Rios. I'm not sure 100%, so don't hold me to this, but I'm pretty sure, I think it either comes from Switzerland or Germany. And the way that you go about it is you will have to send them the CBCT and a scan, a digital scan, and then obviously you need to fill out a prescription for what you're trying to achieve and what you want to do. It's 3D printed, customized titanium scaffold, reduction of surgery time, easy removal design, which is actually true, because I have had problems with meshes where they're pretty much integrated with the bone and it's been a nightmare getting rid of them. When it comes to tacks, actually, someone else asked me about that. What do you do if you can't get the tack out? Leave it. It's made of biological grade titanium. If you're using the right tacks, is it bothering anyone? Is it going to do anything? No. You know, and if it's going to cause a patient more harm to remove it, then what difference is that between your integrated implant? In fact, you know, the whole way that implantology was discovered or invented by Piers Bannermark was the fact that, you know, he was using these little tacks on these poor little rabbits. So I would just leave where it is. High stability and space maintenance, absolutely. Optional, unique integrated prosthesis positioning, and that's what I was talking about. They call it it's sort of CBR backwards. It's immediate or delayed augmentation and extraction alveoli, horizontal and or vertical alveolar ridge augmentation. I think we get decent ridge augmentation on this. You know, not always successful. I've had a patient where we've done a bilateral one. The one on the patient's right has turned out beautifully. The one on the left didn't as much, largely because we had dehiscence. And you have to remember, with a lot of these, where you're doing very large cases with this type of mesh, and with things like large PTFE membrane, and someone asked last time, I think I did mention, I'd forgotten, it's cytoplast that we use, particularly the one with a reinforced titanium back that you can bend to shape. You do get dehiscence. The fact that the one we're permeable, I like to cover this as well with a membrane, allows you some leeway. It's three-dimensional augmentation and reconstruction of bone defects. Okay, it's basically a scaffold. We talked about by Rios. That's basically the theory of, you know, once you've placed it and the bone placed, they then use the guided holes to create the osteotomies for your implants, and then the guide itself is removed. I prefer to do it slightly different unless I end up with a situation like that. And then we'll just go through that in a moment. There's a ridge. So what basically happens is on that ridge, we perforate, first of all, the incision. There's two types of incision. You do a crestal, and you can do what's called a poncho, which you'll see in a moment, depending on the situation. First of all, you need to get vascularization or vascularity of that site. So you need to perforate the bone so that you're getting bleeding coming to the surface. I prefer to use a layered technique. I think some people call it a sandwich technique, but we're professionals. We're not making sandwiches. You perforate it. I prefer to use an autogenous layer on that perforated level, the bone that I've harvested. I then use a 50-50 on top of that, and then fill the rest of the 50-50 into the matrix and put it on top. Prior to that, we would have already tried the matrix in to see that it works and that it's in the right place and we're happy with it. We're avoiding vital structures, adjacent teeth and roots, ID nerve, mental foramen, etc. Sinus, if you're up there, floor of the nose, whatever it may be. And what I prefer to do is actually get those holes drilled in, and knowing if you look at this, you'll see those circular holes, and they're pretty much designed for the screws to be screwed in at any point. And once those are established, then once we fill that with bone and put it in place, we obviously clear that area slightly where we're going to place screws. I can see the pre-hole that I've drilled for the screw out, and then we can screw that in without any problem. There you see a guide for where they're basically taking a scan and using that. I think they're STL files. There's various different types of, which I'll show you other versions of this as well that are used. I think it's that one in the bottom, in the middle, on the lower row that we've just used recently, or that style. So it's custom made. It says you place on the bone defect to create volume, and you both grown into it. Basically, it's fixed by titanium screw, so you're getting stability. And as I discussed earlier, stability is the main thing. And it's basically, they do have a number of checks. I think it takes about, from the design, approval of design, around about 4 weeks to come, but because of the present situation, it may take longer. And you know, you can have immediate delayed, as we discussed, horizontal, vertical, and 3D augmentation. And it's ultimately is a solution complex alveolar bone defects, but it depends on what you want to bring into your surgery. I'm not asking everybody to do this. We do this because we have a great need for it, and rather than referring people, if you can do it, well, why not? So reducing time, easy removal design, which is their registered trademark for it, and high stability and space maintenance. And then obviously you've got this thing called the CBR backward, where you can actually plan your implants at the same time. It also obviously calculates the volume, so you can then make that up with your bone grafting material. Because I use a 50-50, that's fairly easy to do because you just halve what's in there, then you know that you've collected the right amount of autogenous. There's a crestal relieving incision. That's a 3 to 4 teeth. There's a full flap, that is full thickness flap. It's placed according to principles of guided bone regeneration. and you want to mobilize that flap. So first of all, once you've done the perforations, the first thing I do is actually periosteal relieving incisions to mobilize the flap so that, you know, we don't have them problems and trying to get down there and doing relieving incisions once, you know, you've got bone and membrane and everything else in there. That's the poncho flap. Again, it's full thickness and there's no relieving incision in that. This would tend to use for more sort of pronounced vertical defects. And you have to sort of make sure that you prepare the mucoperiosteal flap and debride it of any scar tissue or exposure or anything else that may happen. And then you need to make sure that it's tension free. They're the sort of various designs. You can see that, you know, here where they wanted to place the implants on the left, you've got a defect, you know, I don't really see what they've even bothered putting implants on there. It's fairly obvious to anyone that there's not enough bone there. And there is the design for the placement of implants and augmentation. I find it risky to augment and place at the same time unless I'm doing that in the sinus and there's enough bone at the base of sinus to grip the implant. I tend to prefer to do it as a two-stage, and there you've got the holes for placing the implants. This is just another schematic of it, which you will see in a moment, and I'll show you a video as we finalize through. This is actually production support material. This is what they actually use. Very interesting, that's great. You know, then they're actually the laser sintering that they use for the treatment process, or they're called blasting. And these, there's a microscopic view after the sintering process. That is the mesh itself, and there's more magnified views of it. That is showing you the bone at different magnifications, or sorry, the mesh at different magnifications. And, you know, if you want to sort of download and have a look at this and have a play around, even if you do place or place and don't place or use this, it's quite interesting to have a look for yourself. It's just something that you can see that is available. And then, you know, they've done this, is a Sargev et al. Study where they've taken insufficient bone height and find out whether or not it can be restored. Patient data study design mainly involves sort of 43% maxilla, 57% mandible, virtually half and half for poncho and mid-crestal. Autologous bone was only like just on 10%, and gastric bio for the majority of it. There are a small number that use no membranes, BioGuide with about a third of them, and a double layer with 62% of them. 67% of the patients were uneventful post-operative healing, but there were about 33% exposure and no premature, but did not require premature removal. As I discussed, you know, that tends to be part of the course with this, regardless of what you do. The ideal patient with a perfect surgery, and we've had to of that, and have other ones which haven't gone as well, and there's been no problems. The vertical bone gain was 6.5 millimeters, which is quite significant, 5.5 horizontal, which I think is within the norm. I think most people can achieve that at 6 months. And they found that of the 44 implants they placed, 100% implant survival. Obviously, that's not long term. Here we've got the various uses of it and various designs that they use. And here's a step-by-step surgery, just an animated movie to show exactly what we do. On next week's section, I will include one where we've got pictures of a live surgery. I just wanted you to get the theory this time. That's basically what they're trying to achieve. There is the mesh and design of the mesh, 3D printed. Obviously, of it. This is, I think, a crestal incision on this one. Yes, it is. I wish my flaps opened easily as that. Okay. And there's a check. So you want to check that it fits first. There's the relieving incisions, and you want to go both sides, obviously avoiding vital structures. Know your anatomy, particularly on that lingual aspect, and that is the buccal aspect. That's a bone scraper for harvesting of the autogenous. And then mix with your graft material, biomaterial, bios in this situation. Wetting with blood, as we discussed. That's placement within the mesh itself. And it doesn't tend to fall through, you know, with its consistency, it tends to hold. This is a perforation, and remember, you know, you need to do this with a surgical drill with good irrigation. You don't want bone burn and a burnt bone base to put onto. You want to layer that on first. There's your mesh filled, and there are your screw points screwed in, and there is your membrane to put on top. And wetting the membrane, I actually secure the membrane as well. So I don't really want the membrane moving around or becoming exposed. It gives it less chance of being exposed. Here, we're doing a horizontal mattress suture. And we'll tend to do in somewhere like this, 3 of those with 4 interrupted between. This is approximately 4 to 6 months. I would say 6 months. I would not go back in there prior to 6 months. They're using their pin drill to basically create the spaces. Now this is the breaking of the back of the mesh and removal and implant placement. Time for this placement of the final prosthesis. And it is pretty much predictable when you do that in the right hands, and there's a few tips and tricks to do, but it does work. So it's a great way of building large ridges where you think things couldn't be where you may feel that you're not able to achieve that. Obviously, I'm not asking novices or anybody else to do this. You need a bit of experience, you need some surgical skills. It's not what always goes right, it's what goes wrong and how you can deal with it. Okay, a couple of questions just to finish off. One of them is Dr. Stephen Chin. Hello, Stephen, how are you doing? To remove the titanium scaffold after 6 months, is this time you place your implants? Yes. There's various literature on certain grafts, etc., that, you know, mature early, etc. I like to wait 6 months. There's nothing wrong with waiting. There's everything wrong with rushing things, stitching time. So yes, no, 6 months is exactly when I place. And somebody asked, are there any issues with the lingual nerve when doing the periosteal release? No, there isn't, if you know exactly where you're doing the periosteal relieving incision, but that is important. Where we're doing it anteriorly, particularly, it's the lingual artery that we need to be careful of. But no, we're not really going back as far as the lingual nerve, or shouldn't be, and should be remaining superficial to that anyway, superior to that rather anyway. I hope you've enjoyed part 1 of our bone grafting webinar. As I said, please like our Facebook page. Please follow us on Facebook and on Instagram. Contact us, come down, come and see surgery, come and say hello, come and see anything you want to, come and use some of the equipment there, planning stuff, anything you want to do. I look forward to seeing you next week, where we'll be going more into procedures about some of the materials that we've used step by step, and we will see you then. Until then, stay safe and goodbye.